people, welcome back to our channel MediManiac. In this video, we are going to talk about asthma. What is asthma? Asthma in simple terms is the chronic inflammatory disorder of the airways. It can also be defined as a clinical syndrome in which airways of a person gets inflamed, narrow, along with excessive mucus production, making it difficult for the person to breathe. Asthma may be atopic or non-atopic. The atopic asthma is an extrinsic asthma, means it is triggered by external environmental factors such as allergens. It is the most common type of asthma. Inflammation of the airways is mediated by systemic production of IgE antibodies. Non-atopic asthma is far less common than the atopic asthma. It is a type of intrinsic asthma which is caused by inflammation and constriction of the airways, not caused by an exposure to an external allergen. In this, the inflammation of airways is caused by local production of IgE antibodies. Now, let's take a look at the cross section of bronchioles of a normal lung. As you can clearly see, there is presence of mucous cell layer around the lumen, and outside it is present the pseudostratified columnar cell layer, and surrounding it is lamina propria, and the outermost layer is of smooth muscle cell layer. Now, if we take this section and try to see the histology of normal bronchiole, we can see there is mucus layer present at the top, followed by a layer of pseudostratified columnar epithelial cells. Within this epithelial layer, we can see the goblet cells. These goblet cells are responsible for mucus production into the lumen. Below that, we have lamina propria layer, which consists of mast cells and macrophages. These mast cells are responsible for histamine production. And the lowermost or the outermost layer of the bronchiole is of smooth muscle cells. Now, let us observe how different are the asthmatic bronchiole from the normal bronchioles that we have witnessed just now. As we can see in this, the lumen of the asthmatic bronchiole is very much narrow due to various reasons that will be discussed later in this video. Now, coming to the histology of asthmatic bronchiole, we can observe several changes as compared to that of normal bronchiole. These changes are as follows. The mucus layer has become more thickened due to excessive mucus production. This is due to the fact that the goblet cells present in the pseudostratified columnar cell layer have also increased, causing increased mucus production into the lumen. In asthmatic bronchiole, we can also observe eosinophils in the mucus layer of the bronchiole. Now, as we move lower, we can see that the basement membrane has become more thick as compared to that of normal bronchiole. The mast cells within the lamina propria have also increased, which means increased histamine production as compared to that of normal bronchiole. The other cells that we can observe within the lamina propria is the neutrophils that are normal in the cases of inflammation. The T helper cells are also visible within the lamina propria. And finally, we can see the smooth muscle cell hypertrophy within the asthmatic bronchiole, which occurs due to constriction. Because of these changes within the bronchiole, three characteristics of asthma arise, which can be memorized as a triad of airflow obstruction, broncho hyperresponsiveness, and inflammation. So now let us learn something about the etiology of asthma. As of now, we do not completely know what is the underlying etiology behind asthma, so we can consider this situation to be idiopathic generally. It is related to a specific type of triad. This triad is generally known as atopic triad. In this, certain individuals with genetic predisposition have more of allergic hyperresponsiveness to specific allergens. This atopic triad consists of asthma, atopic dermatitis, which is generally known as eczema, and allergic rhinitis. The other thing that the asthma could be related to is something more interesting, which we call the Samter's triad or the ASA triad. The Samter's triad is nothing but generally a disease characterized by the triad of asthma, nasal polyps, and aspirin sensitivity. So, to learn more about the aspirin sensitivity and its role in asthma precipitation, we must learn first about the arachidonic acid pathway. As we all know, the arachidonic acid is produced by the metabolism of phospholipid present in the plasma membrane of the cells by the enzyme phospholipase A2. Now, this arachidonic acid can undergo two pathways to form various products. These are the COX pathway and the LOX pathway. The COX stands for cyclooxygenase, while LOX stands for lipooxygenase. The COX pathway lead to formation of various prostaglandins like prostaglandin E2, prostaglandin I2, that is prostacyclin, and prostaglandin F2 alpha, and several other products. These have multiple different functions, while the LOX pathway could lead to formation of leukotrienes, which may be leukotriene B4, leukotriene C4, leukotriene D4, and leukotriene E4. This leukotriene B4 is a good chemotactic substance. It is involved in chemotactic movement of various substances in various mechanisms of the body. Leukotriene C4, leukotriene D4, and leukotriene E4 cause massive bronchospasm. Now the question arises that how aspirin interferes with any of these pathways. Aspirin irreversibly inhibits the enzyme cyclooxygenase. Thereby, it inhibits the production of various prostaglandins. So, by inhibiting the COX pathway, it is tipping the balance and causing shunting of arachidonic acid to form more and more leukotrienes. As the leukotriene production is increased, leukotriene B4, leukotriene D4, and leukotriene E4 are also increased in amounts. They cause massive bronchospasm. In addition, they also increase the vascular permeability of the capillaries of alveoli and enhance the mucus production within the airways. And in this way, they precipitate the attack of asthma. Now, apart from these conditions, there are various other conditions that might trigger the attack of asthma, and these are smoke inhalation, which may be in the form of tobacco or air pollution, dust, pet dander or hair, cold, exercise. Another thing that might precipitate an asthmatic attack are beta blockers. Now let us understand the mechanism behind it. Generally, the epinephrine act on beta 2 receptor of the smooth bronchial muscle and cause bronchodilation. But in the case when a person is taking beta blockers, this beta blocker attaches itself to the beta 2 receptor present on the smooth bronchial muscle and prevents the attachment of epinephrine to receptor. Thereby, no bronchodilation occurs and it leads to bronchoconstriction, which might precipitate an asthmatic attack. Now, before we learn about the pathophysiology of asthma, let us quickly talk about the key players causing it. These key players are IgE antibodies. The IgE antibodies are important as they bind on the receptors present on the mast cell, forming the mast cell IgE complex. This complex is essential as it identifies the allergen and cause massive release of histamine. We will talk about the effects of histamine afterwards when we learn about the pathophysiology of asthma. The other important players in this process are eosinophils, the dendritic cells, and the T helper cells. The T helper cells generally are of two types, the T helper 1 cell and T helper 2 cell. The T helper 1 cell are generally present in the lungs while the T helper 2 cells are not present in lungs. However, there is an imbalance in the case of asthma because in asthma, the T helper 2 cells, which are not generally found in the lungs, are upregulated and are found more in concentration. Now, this T helper 1 cell promotes the inflammation by increasing the cell mediated immunity, whereas this T helper 2 cell increases the inflammatory process by increasing the humoral immunity. And as we all know, that this increased humoral immunity would reflect in increased production of several antibodies against the allergen. Now, let us see how these cells work together and precipitate the attack of asthma. Okay, so first of all, this allergen comes inside the lungs. Maybe it's dust, maybe it's animal hair, or any other allergen. This allergen is going to come in contact with a specific type of antigen presenting cell, such as dendritic cell or macrophages. Now, this dendritic cell will phagocytose the allergen, and when it phagocytoses the allergen, it activates the MHC2 molecule present on chromosome number 6 and expresses the allergen within the MHC2 complex on its cell membrane. Now, this dendritic cell, along with MHC2 complex, takes the allergen to the T helper 2 cell. This T helper 2 cell expresses two important things on its cell membrane. One is the CD4 molecule, and the other is the T cell receptor. Now, this T helper 2 cell will interact with the dendritic cell. The allergen will bind to the T cell receptor, whereas the CD4 molecule interacts with the MHC2 complex. Now, upon this interaction, the T helper 2 cell undergoes inappropriate type of reaction and produces two important chemicals, interleukin 4 to produce specific antibodies which are IgE antibodies, and these antibodies will go to the mast cell or the basophils and bind to them. The mast cell express a specific protein on their membrane known as Fc epsilon 1 receptor, which binds with the IgE antibody. As you can see, the IgE antibody is connected to Fc1 epsilon 1 receptor. After this binding, the IgE antibody would trigger the mast cell to undergo degranulation. When the mast cell degranulates, it produces massive amounts of various cytokines and inflammatory mediators. The most important of these are the histamines and the leukotrienes. Now, let us talk about the effects of interleukin 5 produced by T helper 2 cell. The interleukin 5 will activate a particular type of white blood cell, that is eosinophil, which is bilobed and granular in structure. This eosinophil then releases leukotriene and certain other cytokines which are going to attract the white blood cells. They also produce several proteases, and these proteases over time chronically can start to cause tissue damage in the respiratory tract. Now let's see how these products would affect the bronchioles. These histamine and the leukotrienes produced by the mast cells as well as eosinophil reaches the mucosal as well as the submucosal areas of the bronchioles. As we have studied in the concept of aspirin sensitivity, we know that this process produces excess of leukotrienes and this might also aggravate the situation. Now let's see how the histamine would affect the bronchioles. As we all know, histamine is a smooth muscle cell relaxant. But in case of bronchioles, it causes its constriction. Hence, the histamine causes bronchoconstriction. This bronchoconstriction is going to narrow the airway pretty bad. Now, let's first write it out, the consequences of histamine on the bronchioles. The first thing the histamine does is bronchoconstriction, and this bronchoconstriction is going to narrow the airspace. Next thing that the histamine does is it causes the dilation of the capillaries of the bronchioles, and this dilation of the capillaries causes increase in the vascular permeability of the bronchial capillaries. This increased vascular permeability stimulates a lot of mucus production. This mucus buildup also narrows the airspace along with bronchoconstriction. So, the second consequence of histamine is excessive mucus production. Now, apart from these two effects of the histamine also causes the mucosa of the bronchioles to become superinflamed. It gets filled with excessive fluid, eosinophils, and various other components of the inflammatory exudate. So, the third consequence of the histamine on the bronchioles is that it causes the inflammation of the mucosa. Another effect of the histamine, which you forgot to write down, is the increased vascular permeability of the bronchial capillaries. Now, the leukotriene also causes bronchoconstriction. It also enhances the mucus buildup, causes the inflammation of the mucosa, and also increases the vascular permeability of the bronchial capillaries. All these consequences lead to narrowing of air spaces. All these events occur in acute response, but with time and consistent exposure to the allergen, the mucosa might become fibrotic and cause permanent narrowing of the respiratory tract. Asthma is generally reversible if you take away the triggers or treat with appropriate medication. It can go back to normal. There will be no bronchoconstriction, no excessive mucus buildup, and no mucosal inflammation. In this video, we talked about the etiology and pathophysiology of asthma. I hope it made sense, and I also hope that you guys enjoyed it thoroughly. If you did, please hit that like button, comment on the comment section, and please subscribe. In next video, we'll talk about the clinical presentation, diagnosis, and management of asthma.